Thank you and good afternoon, everyone. It's always nice to be introduced with some jazzy music. Molly, I'll let you introduce yourself and a little bit about CVS Health.
Sure. Well, very happy to be here with those of you who are working every day on Medicare policies, as well as all of the allies that are supporting our members. CVS Health, as you may know, participates in the Medicare program through our Aetna business line. So we participate in 46 states, either through Medicare Advantage PDP programs, or SNPs, and we serve over 11 million members. So I think we're going to be talking a lot today about SNPs, and we are in 31 states with our D-SNP, and we're serving just over 500,000 members.
Good. Thanks, Molly. And if we could go to the next slide, please. The Special Needs Plan Alliance is the only organization specifically representing only Medicare Advantage special needs plans. We are heavily mission-driven. We think of ourselves as a thought leadership association, and less so a traditional trade association, not to disparage our partners, but that's really where we stay focused and we live and breathe that mission statement. We represent 58% of the roughly 13,000 special needs plans in the country. So we have a good reach in terms of our thought leadership work, as well as our research about the special needs plan population in general. Next slide, just a quick blip for folks that are not familiar with special needs plans. Thank you. I knew I'd forgotten something. The three different types of special needs plans. There are dual eligible special needs plans for people that are eligible for Medicare and Medicaid, who by definition have complex conditions because they're eligible. For Medicaid, they typically are low income, thus eligible for Medicaid. And they also are difficult typically to engage and reach due to health literacy issues and to help them understand how to engage in their care. The other two are chronic condition special needs plans that are targeted people with very complex care needs, well beyond the threshold of simply having diabetes. They'd have multiple comorbidities, or the chronic condition they have is significant to the level that the primary care lead needs to be a specialist in the type of care that they need. These folks don't need to be Medicaid eligible, but they typically are. The final is our institutional special needs plans that are targeted to people that reside in typically nursing facilities, but we'll talk about some innovative approaches that we have going forward there. In terms of our population, this slide really lays out the differences between the individuals we serve relative to Medicare fee-for-service and traditional Medicare Advantage. Not to disparage our partners, but our population is 100% complex, both in terms of their medical needs, as well as their social supports, social determinants of health, or we actually prefer the term social risk factors. And what you see across the bottom of the slide are the prevalence of disability, cognitive difficulty, which primarily is some form of dementia, housing insecurity, and food insecurity. And it's also important to point out, as I alluded to earlier, that most special needs plan enrollees are dually eligible, irrespective of which of the three that they're eligible for. So Molly, would you want to talk a little bit about how we're best positioned to serve special needs plan populations?
Absolutely. So just a reminder, all of our special needs plans are part of the Medicare Advantage program. So as a baseline, we're following all of those rules that are in place. I like to think of SNPs as kind of going above and beyond. What we do is start with a model of care that we submit to CMS, and it really describes how we are going to care for this specific population. In our plans, we often have a care manager that is assigned to all of our SNP members. This individual helps them understand and identify their priorities. Are they trying to become more mobile in the community? Are they trying to have the energy to spend time with their grandkids? Are they trying to make it to bingo on Saturday night? So it starts with really understanding who our members are and what they expect from us as a health plan, as their partner, along with all of their providers, their caregivers, their allies, et cetera. So you can see here some of the elements of the model of care that talks about our network, the various measures that we're holding ourselves accountable to and that states are holding us accountable to. Because the other really critical element of all of this is that D-SNPs participate in both the Medicare program and the state Medicaid program for the service area that we're in. So that means on top of all of the CMS Medicare Advantage rules, we're also contracting with the state Medicaid department directly. We have documents that are required each year to get submitted along with our bids that are called SMACs. That's the state Medicaid administrative contract. And that includes another framework of priorities and requirements that the state really wants to ensure that we're abiding by when we're serving this vulnerable population. We also work with the states to determine which benefits are best for that community. We know that some states are really focused on transportation. Other states are really focused on the unique issues that present themselves in a rural environment that we heard John talk about earlier. So there's a lot of flexibility and opportunity to partner with the states and those that are involved in those communities to determine the best program for those individuals. So we are specialized, we are local, and we go kind of above and beyond the traditional Medicare Advantage requirements.
Thanks, Molly. And a couple of other things that I would add to Molly's comments are an emerging trend of younger adults that are dually eligible for a variety of different reasons. That folks that when their parents pass away, a bit morbid, that they become Medicare eligible on the basis of how their parents' Social Security benefits transition over to the younger adult. And they become Medicare eligible on that basis. So we're really thinking forward and innovating around our models of care, in particular for young adults with severe mental illness, persons with intellectual disabilities, and more often than not, both in terms of their care needs. And another area that's very important to us in terms of thinking forward are based upon that and the number of special needs plans and the complexity of this population are working with state health insurance programs and helping them to understand special needs plans as well as the types of services that we offer and directing those individuals to us rather than traditional Medicare Advantage when they need that sort of specialized model of care driven service approach. And the purpose of this slide is just to show how expansive the special needs plan market and infrastructure is across the country, and that it is well established. We've been permanent since 2018, and as you'll see on a subsequent slide, the growth has been pretty substantial since permanency and since we've begun to work with states more closely. Begun work with SHIPs but are looking forward to further expanding that work. We'll be delivering some special training to the ACL, the Administration for Community Living, and the SHIPs over the next couple of months to help them better understand these groups. So Molly, next, I think we wanted to understand some of the quality measurement challenges that we'll be talking about, and I'll put the slide up with our biggies and turn it over to you to talk.
Sure, and I'll kind of frame it from a higher level and let you go into a bit more of the specifics. But as I mentioned, when we're thinking about quality, making sure that we understand what the requirements are on the federal side as well as the state side. So a lot of it comes down to data and reporting and trying to make it as simple as possible. We were very much encouraged by some of the steps that CMS has taken recently to have a streamlined reporting from the health plans to CMS. Things like encounter data, the states have autonomy and flexibility to put those reporting requirements into our contracts, but they can vary across every state. And so if we're spending time understanding, the data interface platform and how they want the data provided in each state, that's time and energy and resources that maybe we could better deploy to, speak and interact directly with our individuals. So when we think about quality, one of the kind of overarching points that I would make is that figuring out a way to be efficient with reporting so that we're not spending extra resources trying to navigate individual requirements across a lot of different programs. There is a lot of opportunity to kind of reduce unnecessary reporting and try to streamline it through one body, which I think would be also beneficial for the states. They're getting it from a single source, from CMS. They don't have to deal with negotiating with each health plan to say, do you have these data elements on quality? We need it in this format. So from a big picture standpoint, there's still a lot of work to do to better integrate the Medicare and Medicaid programs just from the perspective of getting the information. But I know there's some specific priorities that we have within each of the quality programs, and I'll let you kind of opine on those.
Sure. So more data from CMS is something that we desperately need to better understand how special needs plans are operating and to help us really drill down on better understanding, in particular, the Health Equity Index. This is something that's particularly important to us because of the complexity of our population, both in terms of clinical characteristics, social risk factors, as well as the cultural diversity is something that's very important to us, and making sure that that's accounted for in the populations that we serve. Making sure that, of course, the health outcomes survey information helps us identify some of those elements is a big priority for us that we've been talking to CMS for a while about, and we hope to continue to have a productive dialogue with them around. And then lastly, all of this data would feed into a much clearer picture around the cut point thresholds, specifically around Health Equity Index and how that impacts reimbursement for special needs plans. And we're not an organization that talks about payment all the time. We're an organization that talks about accurate and appropriate payment to deliver care to a complex population, and to make sure that we have the resources to do that in the context of the folks that we serve, and that we are laser focused on making sure they get their needs.
Absolutely. I think accurate and complete information kind of goes back to that original point of we really need to understand our members, what both medical, physical, mental conditions they're facing, as well as all of those social determinants in order to get a clear picture. I've been really encouraged that we're starting to report on social determinants of health through the required health risk assessment. So this is another element that's unique for SNPs, because we are required by CMS to conduct a health risk assessment on all of our SNP members. And recently they've added 3 questions on social determinants of health around, I believe, transportation, housing, and food insecurity. So that is terrific, because that is more standardized information that we're getting about our members. I would love to see that pulled through to other elements of the program, so that we're really looking at social determinants of health and how they impact health outcomes, how they impact the resources we have to care for this population as well. But I would be remiss if I didn't start with health risk assessments there.
Sure. No. Thanks, Molly. And it actually the health risk assessment piece actually goes to a higher level. It's statutory, as well as CMS, rigorously overseen by CMS in terms of how we use them. They have to be tied back to the model of care through a clear line of sight that's overseen by NCQA. There also has to be a clear line of sight to our interdisciplinary care teams and the plans of care from those assessments that have to be conducted at intake and annually for the individuals that we serve. So that's another important point. And from an organizational perspective, we have a project underway called the Beneficiary Complexity Index that we hope to work with CMS on their quality metrics and understanding the population, where we're looking to pull in data from other parts of the federal government to provide a more composite picture of the individuals that we serve. I think I noted housing insecurity and food insecurity is something that we're looking for. Some of that information came from the Medicare Current Beneficiary Survey, but there are other data sources within the federal government that we think could provide a better picture in terms of how we serve individuals. In the final rule this year, something called the 4-pack. They are 4 specific policies that are intended to help guide individuals that are fully eligible for Medicare and Medicaid into fully integrated products. At broad brush, there are a couple of specific things to understand. CMS front and center was concerned about what their term for is choice overload. That there were too many D-SNP products or dually eligible special needs plan products in the marketplace for full duals, people that are eligible for the full array of Medicaid benefits, not just Medicaid paying for the Medicare copays and deductibles, but fully eligible for Medicare, fully eligible for Medicaid. Being able to easily find those fully integrated products and enroll in them. So one of the core pieces that CMS implemented was that there has to be, for each parent company, only one fully integrated product in a given region for a Medicare Advantage plan. They are allowed to have one other D-SNP product in the market, but they're limiting to those 2 by parent company to try to address the choice overload piece. There also are an array of special enrollment periods and crosswalk requirements as these are rolled out between now and 2030. We really look forward to working with CMS on the opportunities to move forward with moving more individuals into fully integrated products and starting to think through how to work with states around these products and a couple of different approaches, and I'll turn to Molly after I finish bloviating about these couple of important areas. D-SNPs are required to have enrollee advisory commissions, which is a good thing to provide input on lived experience. State Medicaid programs have a new requirement for Medicaid advisory committees. MCACs, which was the predecessor to the 2 I'm going to describe very briefly, were mostly check boxes for advisory bodies into Medicaid agencies. I was the deputy director for Medicaid for the district for years. We'd call people in, to give them some coffee and throw some cookies at them and listen for an hour and walk out. These have to have much more, the new models have to have much more meat behind them in terms of recommendations being addressed. They have to be publicly posted. And there's also a beneficiary advisory group that feeds into the Medicaid advisory group. So as we think about all these moving parts with an integrated product and limiting products to reduce choice overload, there are a lot of different plan moving parts, a lot of moving parts for individuals to understand what their choices and options are, as in some instances they are crosswalked into a product and they are informed about that. And then how states manage across the different beneficiary advisory groups that will be providing input to them on how this should work, because there are 2 for the states and then 1 for the plans. For the plans, it's the enrollee advisory group, and then 2 for states. So all of that input will have to be synthesized into a broader picture for how all of this works. And I've talked a lot, Molly. Do you want to talk a bit about what some of your observations are around some of these challenges.
Sure. We were definitely encouraged that dual eligible SNPs and integration has been on the forefront the last couple of years with CMS in the states. We're in a very interesting time because when I think about these 4 new provisions, it's really enabling states by giving them more tools to say if they're ready to move down that path of integration. They're ready to move from just coordinated care to actually determining how we're going to integrate Medicaid and Medicare benefits, how those long-term services and supports and behavioral health work with all of the Medicare Advantage supplemental benefits. How do we ensure we're not duplicating and we're being as mindful and thoughtful as possible about what we're offering to these individuals? There's a lot of change coming and we're still waiting, excuse me, to see how states are going to receive kind of all of these new opportunities and tools. Because the really important thing about SNPs is it's a partnership between not just the health plan and CMS, but the state, the health plan, and CMS. So we're kind of in an interesting time where we're talking with states to determine what are their priorities. Are they going to be taking advantage of these new options for integrated plans? How does that work with the Medicaid program? We know that Medicare Advantage beneficiaries traditionally can shop and change plans during the annual enrollment period. Well, now there's a special enrollment period for integrated plans, for integrated D-SNPs. Does that align with the annual enrollment period? We're not sure because it has to take into account when the Medicaid enrollment period is. So there's still a lot of nuances in operationalizing all of these steps forward, and a lot of it is dependent on state Medicaid agencies, how quickly they can move forward, whether they have the resources and knowledge to spend time learning the Medicare Advantage program and what that requires. I will say the 2 programs have very different timelines. So when we're submitting our Medicare Advantage bids to CMS, we might not have our SMACs with the state signed yet. And that's because of the deadlines of the 2 programs. So this is a great step forward. I would say we're eagerly engaging with our partners at the state level to figure out if they are going to take some time, if they're trying to move forward quickly, and then how that will impact all of the beneficiaries. Because I think the last thing that we or CMS would want is to make the shopping and enrolling experience more difficult. So it's going to be an interesting time as this plays out. There's a lot of changes happening in the marketplace, especially with states and Medicaid redeterminations and coming off of COVID. And so we're asking for stability. I think we need a little bit of time to work with our partners to see how these provisions will go into place, what tweaks are needed to make sure beneficiaries are not getting disrupted. And so it's definitely an interesting time to be in the SNP space.
No shortage of things to think about going forward. So the next piece, is thinking about enrollment trends and what SNP should play in terms of role as we think forward about the new emerging complex care population. And the piece that we want to punctuate with this is the enrollment trends in special needs plans as evidence that there are. I think that the aging boom and the need for long-term care and special high-need populations, individuals over age 85 and special needs has become white noise. No one's talked seriously about the age wave, I think, in a while. Everybody thinks everything boomed 3 years ago and we're past that. Well, we're not. In the next 5 years, the number of over age 85 individuals will increase by roughly 21%. And then going out another 5 years past that, there's an additional 30% jump in over age 85. That's pretty substantial, my friends, in terms of the number of individuals that need targeted care. Most of them are dual. Most of them are increasingly childless as you look at the out years, so that $3.8 billion in family caregiver support that's in kind delivered will erode over this period of time. The number of medications that they are on is roughly 12. 15 in some, particularly chronic condition special needs plans. So the infrastructure that we offer as these populations grow is particularly something important, and to understand that our infrastructure is critical to forward thinking about policymaking and the role that we play in terms of ensuring that we are there to support these types of populations. Some things that we're really excited about in terms of working with CMS, and I'd be remiss in discussing the institutional special needs plans and chronic condition special needs plans a bit. CMS expanded into those congregate settings I mentioned earlier. For older adults. In this particular instance, these are this is a policy clarification from CMS that institutional special needs plans can now reach into settings that we've traditionally thought about as home and community-based settings. So adult residential care facilities, adult foster care, for older adults, and for home and community-based settings for younger individuals that are eligible for Medicare and Medicaid, and I noted that that's a growing population. So we're in a dialogue with CMS about how that can be coordinated. And that's also ripe for work because most of these folks, as I noted, are Medicaid eligible. And for an institutional special needs plan, part of the eligibility criteria for being eligible for an institutional special needs plan is meeting the state's level of care for Medicaid purposes. So this is something that we're excited about in terms of being able to coordinate Medicare services for populations where this has typically not been done. They've simply been in Medicare fee-for-service. So it's an opportunity for us there. And CMS also has added an array of additional chronic conditions that chronic condition special needs plans can target, as well as new groupings. There are certain chronic conditions that CMS groups together that have integrated, no pun intended, needs in terms of services, specialties, and types of medications and other types of services. So we're looking forward to working with CMS on better understanding how those can play out, and in particular understanding and making sure that those sorts of care opportunities that are better tailored for these individuals really unfold. And I think that two good examples of chronic condition special needs plans that have not played out the way we would have hoped, and I think CMS as well from our discussions with them, are C-SNPs targeted to persons with behavioral health support needs. There are none. And there were 3 dementia special needs plans, all 3 of which had been shuttered. Due to challenges with designing the services and benefits. They're being rolled into institutional special needs plans, and their care is being targeted to the best of these plans' capacity to address dementia care needs through through SSBCI, those special supplemental benefits for the chronically ill. So these are things that we want to work with CMS on in terms of innovation going forward. So we have a lot to work with, a lot on our plates. Molly and I have taken up all but 30 seconds of the time, but we're happy to hang out for a minute and answer questions, or you know how to reach us. My email address is, I think it's on the next slide, and then we're on this thing called the internet. So you can also reach us there at snpalliance.org. So Molly, thank you for making time. Our members are always slammed with keeping up with work, and we appreciate your attention this morning. So thank you very much.
Yes, thank you.